put under, I guess. You sort of have to regulate their oxygen intake.
Yes.
How exactly does that work?
Well, it's going to be a little bit different in the operating room, but your application, I think could be used throughout any hospital setting. In the operating room, when people come in, we'll put an oximeter on their finger, and we'll look at their baseline oxygen saturation, and we pre-oxygenate everyone. And you guys, you obviously have the oxyhemoglobin saturation curve, but when it gets up here and it's 100% saturated, your PaO2 can be anything from possibly, 80 upwards to 500,
Yeah.
So we do fill the lungs with oxygen so that we denitrogenate people. So that gives us more time before they get back to this point where their PaO2 is dropped, and now you risk that they may begin to desaturate. And so we're way out here sometimes getting started. But during the case, we'll adjust this oxygen concentration so that the saturation remains up in this, 95 or greater area. The issue really is all the medications that we use are heavy sedatives, right?
Yeah.
And sedatives, they shift your CO2 response. And it causes some respiratory depression, right? Do you guys know this part at all? Have you guys studied this yet?
I know.
We haven't talked about this in detail.
Very.
But this is, I think this is really the large application around sedation and anesthesia. But when you shift your CO2 response and you depress it, people hypoventilate, and then there's an equation, the alveolar gas equation, which you guys should look up. Have you seen that?
Yeah, I've seen that.
Okay. So based on just hypoventilation alone, you can drop the oxygen concentration, that PaO2, right? The alveolar oxygen tension. And that's directly related to your, oftentimes to your oxygen tension inside your body. And so on the basis of hypoventilation alone, you can show that that's one of the reasons for hypoxia. So we do that all the time with sedatives. And all the medications, all the anesthetic agents are different medicines, but they're all sedatives. They're benzos, they're narcotics, they're hypnotics. And this may be a little bit weird, but that's really the issue. So now a person goes to the recovery room, and we put them on supplemental oxygen so that they are less likely to desaturate simply from hypoventilation. Okay?
Yeah.
And we don't have a feedback loop. There has to be somebody watching that saturation curve and adjusting the oxygen concentration. But if you had the ability, as just, you'd still need people around, obviously, to monitor all of this, but if you had the ability for a system to intervene early so somebody begins to desaturate and the oxygen flow increases, because you can increase the FiO2 by increasing how many liters per minute. And you could probably, normally the PaO2, have you guys talked about this?
We've talked about PaO2 and SaO2. I think we understand the difference between that.
Okay. So normally, room air is 21% oxygen, but you can increase the percentage of oxygen delivered with a nasal cannula roughly to maybe 30, possibly 35% by increasing the flow. But most people are put on about 2 liters per minute. And an adult, every liter per minute roughly correlates to maybe a 2 or 3% increase in oxygen. So you go from 21% oxygen to maybe 24 or 27% oxygen with a couple of liters. But as people, if they were to desaturate a little bit, the very first thing you want to do is to supply more oxygen. So your idea is in that context, a great idea to have that ability to do that early. Does that help, or is that kind of what you're thinking? Because when you proposed the idea, I thought the application was really more in the recovery room or in the setting of people who are sedated. In the operating room, we do monitor people minute to minute. I mean, the monitoring is continuous and is done by a human, and you need that. When people, when their sats drop, we have alarms set so that the alarm will indicate that we need to do something. But that's kind of the background. So, what questions do you have about just that piece of it?
Matthew, I have the sheet.
So when they're in the recovery room, you have people monitoring them basically all the time, right?
Everybody is monitored until they get back to the point. So, okay, and this is just kind of a visual for you guys. Like, here's being awake, and here's general anesthesia. And so, for us, it's just a continuum. So the medications, like I mentioned, are different medicines, but they're all heavy sedatives. And if you use just one medicine, you know, like a Versed, which is a lot like Valium, people will still interact with you, but they'll feel tired. They may not, they feel less anxious, they may not, you know, look very much different to you, but and they generally don't fall asleep. But when you start to mix medications together, which is what people do in the hospital all the time, and they're different medicines, but they're sedatives, they work together, they have a synergistic effect to make people sleepier. And that's what people are taking advantage of. And they have different medicines. So now I'll take a medication like a Valium medicine and I'll mix it with a narcotic, like morphine. And I'll mix those two together. And now the person is very likely to fall asleep. And so they get sleepier. When they get sleepier from sedatives, they become less responsive to stimulation. So now the person's talking to you. Now you have to gently rub them to get them to respond to you. And if I continue to give them more medicines and add different kinds of medicines, I make them sleepier and sleepier so they become less and less responsive to stimulation. And eventually, it's general anesthesia and you're unresponsive to anything, including surgical stimulation, all right? So we work along this continuum. So in the people are monitored continuously, gets back to your point, until they metabolize enough of the medicines that they get back to the point where they're just tired, which is minimally sedated. And then people remain tired for a long time because it's a little bit of this, a little bit of that kind of keeps them in that condition. But people need to be monitored along that continuum. The dangerous period is when people are maybe deeply sedated and less responsive, and they need some supplemental oxygen. And you know, there's a nurse around, but the person may not be directly working with them. And so as their saturations drop, you know, before the alarm goes off, you could start to give them some supplemental oxygen to buy a little more time so that the person could, you know, get in there and do something before the patient was injured from a low oxygen saturation. How was that? Does that make sense?
Yeah.
Okay.
So, I guess in the hospital, when you're delivering oxygen to people, like what kind of method do you use? Is it just like a face mask type thing, or?
So there are different ways that you can, you know, apply oxygen, but you have to get it near the person's face, and it moves anywhere from, you know, just blow by oxygen. You know, we're just blowing in this general environment in front of their face, to a nasal cannula. Then the next thing you'll see people use is a simple mask, and I'll talk to you. And then they'll use a mask with a reservoir. And then they'll start to apply other devices. Like there's a device called a laryngeal mask airway, which just supports the tongue in a very sleepy patient, all right? So the patient goes, everybody who we sedate, they go like this. So we take something and put it in the mouth to support the tongue, to open the airway, okay? And then sometimes we'll place an endotracheal tube, an actual breathing straw in the trachea. And that's, you know, for most surgical procedures, that's one of the more common things that we do, is we'll intubate someone and we'll put them on a ventilator. So there is this spectrum of ways of delivering oxygen. The thing about it is, like, if you put a nasal cannula in someone and you're delivering oxygen, which is what your device, I think, the initial piece of it suggests that you might start there. The reservoir is the oropharynx. So at a certain point, I can turn the flow up higher and higher, but I can't really deliver more oxygen. So when I take a deep breath, and you guys talk about this?
A little bit.
Okay, so when I
talk about fraction, or the entrainment of the air and that blending and all that. Yeah.
So this is what you kind of need to know.